We are very lucky to have Dr. Ragland from Virginia Mason Franciscan Health, who will be speaking to us about critical care medicine for the boards. Dr. Ragland, if you want to go ahead and share your slides and take over.
Great. Sounds good. Great. Thank you so much, Dr. Shinoy. It's a privilege and a pleasure to be here. So thanks for the invitation. Thank you everyone for being here. And again, thanks so much to the Washington ACP for inviting me to speak again this year on critical care medicine for the boards. We have an hour today, and I will say this twice, but there's so much to cover. I will go through the slides that I have prepared that sit on the work of two outstanding presenters ahead of me, Vishak Sharu and James Towns from UW. I will blaze through a lot of things. You all will have access to these slides at the end. And so feel free to email me. My contact is at the end if questions come up as you go through this, because given the volume of information and the forum, getting detailed questions answered is a little bit challenging. So we can do that asynchronously after the time. So let's see, we'll flip through. Let me see if I can get this off of my screen so I can actually see my slides. Ooh. No, didn't work. Sharing. Let me try again. Trying to get this off. Okay, still can see it. Okay, thanks. I have no disclosures to disclose prior to this. So just a disclaimer, as others have probably shared with you as they've gone through their slides, the boards versus real life, they're different. In medicine, and as someone in critical care, I would say, especially critical care, medicine and critical care rapidly advancing. And so what you're doing in real life and the current concepts in management can differ from board questions. There's often a couple of year delay and practice changing information, guidelines that come out and what you're seeing on the boards. Therefore, to try to avoid that murky space between practice of recent past and immediate new data that's changing practice, boards questions tend towards more durable or foundational concepts, but even those can change. Again, I will blaze through this very quickly. I have over 100 slides. I'll spend a little more time on the front end than on the back end. The latter slides are a lot more memorization kind of concepts. So if you notice that I'm spending more time on the front, don't stress. We'll make it through, but just at a faster clip towards the end. So we'll start with a case and a question. A 39-year-old man who weighs 70 kilos comes into the ED with fever, shortness of breath, and malaise for 3 days. His blood pressure is low at 82/45, and his heart rate is 122 per minute. His white count is 28,000. His mental status deteriorates and he's intubated. He's given 1 liter of lactated ringers and has started on a norepinephrine infusion, and he has a central venous catheter placed. So question number 1, which of the following is the most appropriate next intervention? A, bolus with another liter of crystalloid. B, increase the norepinephrine. C, start a vasopressin infusion. D, start a dopamine infusion. Or E, start a dobutamine infusion. And then is somebody else running the poll?
Yes.
Okay, great. Great. Okay, so that looks like most everyone. So I'll end the poll. Just for my information, when I flip back to the polling, can you all still see my slides?
Yes, we can.
Great. Okay, thank you. Okay. And then to end the poll, do I click stop sharing?
Yes, you can do that.
Okay, great. So we had 78% people say A, bolus with another liter of LR. We had a couple of people say C and E. The majority of people are spot on, so with bolus another liter of crystalloid. So we'll talk about why that is. So sepsis and septic shock, common topic to cover on the boards. So I'm not going to spend a lot of time on this because this is not what we do anymore, but this still is how a lot of people are taught to think of sepsis. So the old sepsis definitions were anchored on this concept of systemic inflammatory response syndrome, or SIRS. Again, we don't do this anymore, so I'm going to leave this here just as a point of reference, and then we'll talk about how we do things. There used to be a continuation of SIRS to sepsis to severe sepsis and septic shock. And so in the current definitions of sepsis that were put out in 2016 and updated in 2021 with a couple of edits since, we now no longer use SIRS as part of how we talk about sepsis, and we now no longer use severe sepsis. So it's just sepsis and septic shock. And so sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. It's defined as a change in the SOFA score, which I'll talk about in a couple slides, of 2 or greater. And so it's important to remember it's not so much about the infection, but it's about the host response to the infection. So the infection can be relatively little and small, and the host has a dysregulated response to it. Or somebody can have what seems like terrible infection, but their response to it is really not that profound. And so it's defined by how the patient is responding. And then septic shock is defined as if you have sepsis, and then you need vasopressors to keep your mean arterial pressure at least 65, and you have a lactate of greater than 2 millimoles per liter, the standard measure that we all use for lactate. Okay. So what about the SOFA score that's talked about in here? So the SOFA score is the sequential organ failure assessment score, and it's a marker of the severity of your body's response to infection. And so if you have a score that is 2 or greater from your baseline, so if you have, for example, baseline thrombocytopenia, your change in you get sepsis, or you get SOFA score points based on your number of your category changes from your baseline. And so it's defined as it's supposed to be a marker of how severe your response is to infection. I'm not going to read through this whole chart. This is available just about everywhere if you wanted to Google SOFA score sepsis. In full disclosure, I don't write for the boards. However, I think it would be appropriate to learn the systems that are part of the SOFA score. I think it would be unlikely in medicine boards that they would ask you to calculate a SOFA score by memory. So if it were me preparing for this, I would not memorize what's 0 through 4. I would have some concept of what that trajectory looks like. But I would know that it includes the respiratory system, the coagulation system by platelets, your hepatic system, your cardiovascular system, your CNS system, and your renal system. A higher SOFA score has been associated with an increased probability of mortality, and that acute change in 2 or greater, if you have that and suspected infection, you should think sepsis. Just a little bit about the qSOFA that some of you may have heard about. And I'll actually show the whole slide now. So the qSOFA is supposed to be a modified and smaller version, one that you can kind of pull out of your pocket and use and not have to memorize that whole 6x5 table. And it's positive if greater than two or greater of the following are present: if you're hypotensive, if you have an altered mental status, or if you're tachypnic. Getting to the punchline at the end is the 2021 update to the surviving sepsis guidelines actually recommend using it, recommend against using it as a single screening tool for septic shock. Again, it might be worthwhile just remembering hypotension, altered mental status, and tachypnea, which you can remember by the acronym HAT. But because it's not recommended to be used anymore as a single screening tool in this disease process, probably not worth spending a whole lot of time memorizing. What we used to do in sepsis, and what some of you all may still have learned at various points in your training, is early goal-directed therapy. The reverse trial, worth looking at, is just a piece of, at this point, medical history, but how modern sepsis care started. It included a big bundle of care and measuring a lot of things invasively. There's much of this has not stood the test of time, and the reasons why are fascinating, but beyond the scope of this review today. But the things that have stood the test of time in sepsis and septic shock management are giving early isotonic crystalloid, which can be normal saline or LR, and we'll talk in a couple slides about why you might choose one over the other. Maintaining a mean arterial pressure of 65 or greater, and using vasopressors to do that. The rest of this has fallen out of favor due to subsequent data, which we'll review a little bit of. So getting into a little bit more about fluids, and I'll just show all this to start out with. So what we know is that protocol-driven care, or early goal-directed therapy, as I went through in that last slide, versus usual care has been looked at in a number of studies, PROCESS, PROMISE, and ARISE. And at this point, there's no mortality difference, hence why that early goal-directed therapy with lots of interventions measured invasively and lots of different care things directed at those different items is not what we do anymore. This is also interesting to read about if this is something that you're interested in, but this is probably because the quality of usual care has improved. And so we do a lot of early goal-directed therapy as a part of our usual care. So they're not as different as they once were. So no mortality difference between those. The volume of IV fluids has been looked at in a bunch of studies, most recently Clover's, either giving a lot of fluids or a little bit of fluids, and there's no mortality difference. Where things have settled is giving about 30 cc's per kilo, and then using your discretion, and we'll talk about some reasons that you might give more or less fluid in the upcoming slides. But overall, restrictive versus liberal fluid strategy, no mortality difference. And then the crystalloid type, using saline, normal saline, or a balanced fluid. LR is most often the one we use, but there are others. There may be a slightly decreased mortality and maybe slightly decreased need for renal replacement therapy if you give a balanced crystalloid like LR with a little less salt. And so unless there's a reason like a TBI, or if somebody has profound hyponatremia and you're trying to manage that too, you'd probably lean on giving LR because there's really no reason not to, and maybe a little reason to. And so the backbones of sepsis treatment at this point are give fluids and give early antibiotics. Your priorities in sepsis treatment, again, are early antibiotics. Every 1 hour delay in treatment decreases your survival by about 7.5%, which every time I think about that just blows my mind. So giving people early antibiotics, smart choices, not necessarily the broadest, but covering what you think they might have, will definitely decrease mortality. Use your antibiogram and your source suspected source to make your initial antibiotic choices. And then in an ideal world, you'll get culture data that will help you narrow that down. Your fluid resuscitation needs to happen early. So when the patient presents, or if they're a rapid response from the floor when you see them. You want to give about 30 cc's per kilo over that first 3 hours, and often faster if it's possible, and balanced crystalloid over normal saline in most patients. So just to review the other answers in that question, A was the answer. Increasing the norepinephrine, probably not, because they've only gotten 1 liter of fluid and they're not yet adequately resuscitated. Same idea with starting another with a vasopressin infusion, another vasopressor. You don't want to start a dopamine infusion for a similar reason, and also the data has suggested, and there may be an increased mortality risk of using dopamine in sepsis, so we generally don't use it at all. And then no evidence that this is cardiogenic shock, so dobutamine is not going to be your next best move. Moving on, the patient ends up intubated and they're on low tidal volume ventilation at 6 mils or 6 cc's per kilo. Their FiO2 is 60% and their PEEP is 10 centimeters of water. He remains hypotensive after your initial 30 cc's per kilo of crystalloid and MAP of 52 with a MAP of 52. He's in atrial fibrillation and his heart rate is about 100 beats per minute. Labs are notable for a white count of 42,000 and creatinine of 3.1. We can assume that's above baseline. Urine output is 10 cc's per hour. So which of the following will provide the best assessment of fluid responsiveness? Do you A, want to put in a pulmonary artery catheter and get a pulmonary artery occlusion pressure? B, passive leg raise maneuver? C, do you want to look at pulse pressure variation? D, do you want to look at stroke volume variation? Or C or E, do you want to look at IVC diameter variability? A couple more seconds for the last few people if you want to chime in. Okay, great. So we have most people, about a third of people going for B, a couple of people going for E, and then one-ish person going for C. So love that. So the answer is B, passive leg raise maneuver. We'll talk about some of the reasons why and the other answer choices. So fluid responsiveness is one of these holy grails of critical care medicine, and there's no great answer yet. So this is a state of the practice, and hopefully over the course of our careers, things will we will get better insight into what the right thing to do is. So we generally divide fluid responsiveness assessment into two categories: static parameters and dynamic parameters. So what we know at this point, or at least what the evidence tells us, is that static measures are not helpful. So looking at CVP or looking at pulmonary arterial occlusion pressure. And so responders and non-responders look just about the same if at really any cut point of high or low. And so it's about a coin flip. And so to measure these things, especially invasively, when they don't really tell you anything about how your patient is going to respond to fluids is not worth doing. The other part of this is that dynamic measures, where evidence has at least at this point settled on the category we should be in, they seem great. So looking at pulse pressure variation, if you set a pulse pressure threshold of about 12%, sensitivity and specificity near 90%, this seems great. The problem is to get those sensitivities and specificities. You really have to. Your patient has to fit in a narrow criteria and category of the support they're needing. So they have to be. The real kicker is that they have to be on 8 to 10 cc's per kilo of ideal body weight tidal volume, and they have to be passively ventilated, which essentially means that for many people they need to be paralyzed. So they need to be intubated. They need to be on higher tidal volumes than we typically use, and they need to be paralyzed. And so that cuts out most of our patients for this being really valuable. They have to have normal lung compliance, no arrhythmias, and in this patient, they had AFib. Their chest can't be open and normal abdominal pressure. So there's limitations to using these. IVC diameter for a while was the thing we were looking at, but the most recent data is across studies, adding everything together does not seem to be a reliable method to predict fluid responsiveness. So the state of the evidence at this point is that passive leg raise test performs best. If you lay a patient down and you put their torso flat, and you raise their legs 45 degrees, it mimics the effect of a 300 cc fluid challenge without the fluid. And the threshold is an increase in cardiac output of 10% or greater within about 60 seconds. There's a number of ways to measure this. Usually we do it non-invasively. There's some places that have the cheetah. There are some places that have a flow patch. There are other ways to do it. And sometimes we'll just give the fluid bolus instead if the patient has reasons we can't raise their legs. But this is right now where evidence suggests we should be. To just underscore this, the 2021 sepsis recommendations are Surviving Sepsis campaign suggests using dynamic measures to guide fluid resuscitation over physical exam or static parameters alone. In full transparency, the level of evidence is weak with low quality of evidence. But this is where we are right now, and something that hopefully will continue to evolve over all of our careers. So to review the rest of the answer choices on here, pulmonary arterial occlusion pressure is invasive. You have to have a pulmonary artery catheter and is static. So for two reasons isn't what we want to do. Pulse pressure variation, this patient was on lower tidal volumes than you need to really do that entirely validly and wasn't in sinus rhythm. Stroke volume variation, again, onto low tidal volume ventilation and not in sinus rhythm. And IVC diameter variability. At this point, we across in the most recent meta-analysis doesn't seem to add much more than a guess and chance. So moving on with that same patient, the next question. Despite fluids and norepinephrine, the patient's blood pressure fails to respond. And so ultimately you do end up placing a pulmonary artery catheter. I will show this, give a couple seconds just to look at all the numbers. The normal range is in the first column, and the patient's range or the patient's numbers are in that second column. A couple seconds to look at that. I'm going to show the question. A low cardiac index, high SPR. So which of the following is the most appropriate next step in management? Do you want to bolus some more LR? Do you want to administer stress dose steroids? Do you want to start a vasopressin infusion, start a dobutamine infusion, or do you want to start a phenylephrine infusion? Okay. Great. I think most people have answered. So we have about 3/4 of people answering D. They want to start dobutamine, and then a handful of people for B and E. So we'll go through those. Okay, answers D, start a dobutamine infusion, as most people answered. So PA catheters, they're infrequently indicated, though our cardiac critical care colleagues would disagree. And in many of their patients, they are indicated, but in standard ICU management, they are infrequently indicated. They're associated with complications, they're costly, and honestly, we use them infrequently, so they're often misinterpreted. But they remain a favorite on the boards, and so it's worth at least reviewing what normals are and some standard patterns for pathology, because you may very well be asked, and it's not something a lot of us do in clinical practice. Reviewing the type of shock, and then we'll talk about PA catheter numbers that go along with these. Hypovolemic shock, under that blood loss and fluid loss, distributive shock, sepsis, our classic favorite, anaphylaxis and adrenal insufficiency, and then all the reasons that you can have cardiogenic shock from a cardiovascular primary standpoint, as well as pulmonary embolism and tension pneumothorax. I won't read through this. You all can review this after the presentation. But just a reminder to review the classic PA catheter patterns that you would see in these categories, standard categories of shock. So in this patient, it's important to note that their cardiac index is quite low. And they have a high central venous pressure, and they have a high pulmonary arterial occlusion pressure or wedge pressure, as well as a high systemic vascular resistance, which is the classic pattern for cardiogenic shock. And so of the answer choices, starting a dobutamine infusion to increase inotropy is the best one. This doesn't look like a continuation of just ongoing simple septic shock or other reason for hypovolemic shock. Stress dose steroids, you might do if this is pressure refractory distributive shock or septic shock, but probably, but not the answer they're going for with these numbers. If this were septic shock, you would consider starting a vasopressin infusion. And then phenylephrine you might want to use if this were septic shock, but you had some tachyarrhythmias and vasopressin wasn't doing everything you needed. But in this patient, or in this case, it might cause some reflex bradycardia and worsen your low cardiac output index problem. So not the best choice. So moving on to another patient, but also along the theme of pulmonary artery catheter. A 67-year-old woman who has with severe hypotension 3 days following a myocardial infarction undergoes right heart catheterization. There are her numbers. I think they're still on the next slide. What is the most likely etiology of this patient's shock? Is it sepsis? Is it left ventricular failure? Is it gastrointestinal bleeding? Is it pericardial tamponade? Or is it acute mitral regurgitation? A couple more seconds and we'll move on. Okay, we'll move on. So people are all over the map. Had some for left ventricular failure, some for mitral regurg. So this is actually getting at pericardial tamponade, and I'll explain why. So the pattern that you're seeing in this patient is an equalization of end-diastolic pressures, and it results from that external compression of fluid in a fixed space, that pericardial sac. And it can also go along with constrictive pericarditis, but is probably not going to be this acute, nor happen in this time frame after an MI. So that pattern of those end diastolic numbers being essentially the same is one to recognize in tamponade. For the sake of time, I'm not going to review the other answers, but again, you all will get these slides later and can go through why those were not what the question was trying to aim at. So skipping back to our first patient, the patient who presented with septic shock, and then we decided they had a component of left ventricular failure as part of it. And we started them on dobutamine. So you started them on dobutamine and their cardiac index increases. Over the course of the next 3 hours, he still remains hypotensive. His CVP is still elevated at 18. His norepinephrine is at 0.1 mics per kilo per minute, and his dobutamine is reasonably high at 10 mics per kilo per minute. You're called to the bedside for new atrial fibrillation with rapid ventricular response and heart rate of about 130 per minute. The vasopressor requirements are unchanged. Which of the following is the most appropriate next step? Should you increase the dobutamine? Should you increase the norepinephrine? Should you C, start vasopressin? Should you D, start dopamine? Or E, should you bolus another liter of LR? Right. We will move on. It looks like a majority of people wanted to start vasopressin, and a couple do a couple of the other answer choices. So we will walk through those. Okay, so answer C, start a vasopressin infusion. And so, worth reviewing the receptor activity of all the vasopressors. They're probably not going to ask you which receptors a specific vasopressor acts on, but if you're trying to pick a vasopressor for a specific situation, they ask you about knowing their receptor activity is helpful. The cool thing about vasopressin is it's not a catecholamine, so it doesn't have alpha and beta activity. It binds to V1 receptors on smooth muscles to cause vasoconstriction. And so it can avoid worsening tachyarrhythmias, especially in a patient with septic shock, though we use it often in cardiogenic shock as well. So key point for sepsis management and vasopressors is that your first line is most often going to be norepinephrine. The sepsis guidelines give you the option of using epinephrine. Standard practice, most places is to use norepinephrine, but both of those are options. They also say that vasopressin can be added and may help decrease your norepinephrine dosage. So we often think about that as our second vasopressor in septic shock. I would not increase the dobutamine infusion rate because it can worsen your arrhythmia. It's potently beta active. I wouldn't increase your norepinephrine infusion rate for the same reason. Dopamine really can worsen your arrhythmia, so I would also not do that. And then probably not bolus another liter of LR because there's no indication in the question stem that you're hypovolemic. So moving on to a related topic of respiratory failure. So it's the next morning of your septic patient. This is their chest x-ray. They are on a ventilator on volume control. They have a tidal volume of 700 cc's or milliliters. The respiratory rate is 18 and their FiO2 is 0.5, 50%, and their PEEP is 5. They have an ABG that's 729 with a PCO2 of 35, a PaO2 of 58, and then their calculated bicarb on that is 20. So for this patient whose predicted body weight is 75 kilos, which of the following is the most appropriate intervention? Should you A, change to pressure control mode, B, increase respiratory rate to 24, C, decrease tidal volume to 450, should you D, start inhaled epoprostenol, a pulmonary vasodilator, or should you E, start high frequency oscillatory ventilation?
Dr. Ragland, would you be able to toggle back to the stem?
Mm-hmm.
Thank you.
Yeah.
And then back to the select
Mhm.
the second. Thanks. Appreciate it.
Yeah, not a problem. Thanks for asking. Okay, we'll wrap up there. Okay, so we have about half of people that want to decrease the tidal volume and then a smattering of some of the other options. So we'll go through. Oh, the answer was to decrease the tidal volume to 450 cc's. So I'm imagining that the questions that you get about mechanical ventilation may very well be on acute respiratory distress syndrome and how you manage ventilation during that. It's one of the few areas in critical care medicine, especially with ventilatory failure, that we have data and guidelines. And boards loves to test places where there are guidelines. So the Berlin criteria are worth reviewing. It's how we diagnose the acute respiratory distress syndrome or ARDS. There are shortcomings to that. And so there is a modified recent update in the last few years to the Berlin criteria what's called the new global definition of ARDS. And it's the same principles, but it allows for diagnosing ARDS in resource-limited settings, or and also when you're managing ARDS that's not on the ventilator, so you can quantify it to some degree. You need to have bilateral opacities on any imaging modality. You either need to be on high flow nasal cannula at more than 30 liters per minute. They don't actually specify the FiO2. Or non-invasive positive pressure ventilation, or invasive mechanical ventilation with a PEEP of greater than 5. You need to have a PaO2 over FiO2 ratio of less than or equal to 300. So the higher your PaO2 is and the lower your FiO2 is, the less sick you are. And the lower your PaO2 is and the higher you have to set your FiO2 to get there, the sicker you are. Or you can calculate that ratio on a pulse ox. There's some criticisms of this, but they're of interest but less relevant for the boards. So there are a few things that we know that save lives in ARDS, and I think this is fair for boards to ask. What we know is that low tidal volume ventilation, which is generally defined at 6 to 8 cc's or mils per kilo of ideal body weight based on height, because your height and your lung size and lung volume are somewhat correlated. We know that if you treat, the number needed to treat is 11 if you use that strategy over using higher tidal volume ventilation. So we know we want to use low tidal volume ventilation. We used to actually do early neuromuscular blockade, and I'm going to age myself, but we did this during my residency. And then subsequent data has shown that early neuromuscular blockade paralysis does not save lives, so we don't do it. We do know that prone positioning for 16 hours per day within 36 hours of ICU admission has a number needed to treat of 7. So there are, let's see, I don't know if, I'm not sure if I have this slide, but it's worth reviewing who should be prone. But the key part of that is that we should do it early and we should do it often, and the mortality benefit is doing it early. Low tidal volume ventilation. This is a review of the data from the seminal study in this. I won't review it, but it's worth reviewing. So then I'm just rounding out the answer question or the answer options here. I wouldn't change to pressure control mode because there's no data that says that one mode is superior to another. And we use pressure control less frequently on the whole. Increase respiratory rate to 24, probably not. The guidelines say that we can, people can have pHs of down to 7.15, and that's okay. So we can spare giving them larger tidal volumes. So you have a lot of flexibility there. So you don't need to increase the respiratory rate. You do want to decrease the tidal volume to 450. You can do the math, but 700 cc's for his, I think it was 75 kilos. Is over the 6 to 8 cc's. You don't need to start inhaled epoprostenol. It'll improve oxygenation, but there's no mortality benefit, and we use it as a salvage option and as a general concept, though sometimes in specific patients. And high frequency oscillatory ventilation isn't used in adults. Some more ventilator data for this patient. Tidal volume is 450 cc's. His respiratory rate is 22. His actual respiratory rate is 22, so he's not breathing over what you set. FiO2 is 0.5 or 50%, and his PEEP, his positive end expiratory pressure, is 5. You can see his new ABG at the bottom, 751, so he's alkalotic. His PCO2 is 32. PaO2 is 76 and a calculated bicarb of 6 or 20. I'll toggle back to the question, or excuse me, the data in a minute. What is the most appropriate intervention at this time? No change in ventilator settings. Should you increase his PEEP to 10, decrease his FiO2 to 40.4, increase his tidal volume to 600, or should you decrease his respiratory rate to 18? I'll go back and then we can open the poll though. question. Okay. Okay. So we've got most votes for E, which is correct, decrease respiratory rate to 18. General concept of ventilators is you can only set one of volume or pressure. And so if you set the volume, you're going to monitor the pressure that the lungs see from that fixed volume. Or if you set a pressure max that you want your lungs to see no pressure higher than that, then you're going to monitor the volume that goes in them to achieve that. For the sake of time, I'm going to skip over this, but is a value to review. And what most of us will use for volume control, what your different options are with the ventilator, and what you can set, and what happens as a result of your setting, your independent and dependent variables. Worth knowing about minute ventilation because that plays into what you're going to do with your ventilatory settings. What impacts ventilation and what impacts oxygenation, so if we need to make ventilator adjustments. Some standard out-of-the-box ventilator settings and how to think about that, which is good for clinical practice in addition to the boards. I'm not going to review the rest of the answers again for the sake of time, but this will all be here for you. Next patient, 74-year-old, comes into the ED, calls 911 for difficulty breathing. He's in moderate distress and is using some accessory muscles to breathe. He's alert. He has severe COPD and he uses home oxygen. Temperature is 36.5, little hypertensive at 160/92, heart rate of 118, and respiratory rate, he's tachypnic with a rate of 35. His ABG is 726, 88, with a PaO2 of 72, and he's on 35 liters of FaO2 in a face mask. Here's his chest x-ray, which shows he's hyperinflated. You can see a lot of ribs, and he's got some flattened diaphragms, which would go along with his history of COPD. He is treated with corticosteroids and nebulized albuterol and ipratropium, but he still remains in distress. So what do you want to do next? Should you intubate and start mechanical ventilation? Should you start Heliox, a mixture of oxygen and helium via face mask? Should you start continuous positive airway pressure? Should you start bilevel non-invasive positive pressure ventilation? Should you perform bilateral tube thoracostomy or put in chest tubes? I told you let's open the poll, but I can go back to the data. Okay. Great. So most people are saying D, start him on bilevel, non-invasive positive pressure ventilation, or BiPAP, the brand name that we often use. Yeah. So worth reviewing the difference in CPAP, or continuous positive airway pressure, and bilevel non-invasive positive pressure ventilation, or BiPAP, or NIPPV, which is non-invasive positive pressure ventilation. CPAP has one pressure, bilevel has two pressures, an inspiratory pressure and an expiratory pressure that's lower. There are some crossing over, but slightly different indications for both of them. I think there's a couple of important tenets to remember. And one is, if your patient has progressive respiratory failure and you don't think it's going to get better soon and you think it's going to be worse, I would not use non-invasive positive pressure. I would just skip to intubating them if you think you need to. Non-invasive positive pressure ventilations require an awake person who's not vomiting, who's able to remove their mask if they were to vomit. They can't have facial surgery. They can't have excessive secretions, anything where they're really not able to manage their actual airway by themselves. And so those would be your contraindications. There are a few indications, including hypercarbic respiratory failure from a COPD exacerbation, cardiogenic pulmonary edema. Those often respond quite well to non-invasive positive pressure ventilation. There's some data suggesting that if we use non-invasive positive pressure ventilation in COPD, that we can lower mortality and intubate fewer people. So it's in a patient who doesn't have contraindications, it's worth a try in COPD. There's also some emerging data for the same in asthma, which makes sense given their similar pathophysiology. So you can review the other answers when you have these slides. Moving on in this patient's course, despite putting them on appropriate non-invasive positive pressure, they deteriorate, they're obtunded, and so you make the decision to intubate them. Their tidal volume is 800 mils and their respiratory rate is 20 per minute. But 5 minutes later, after you intubate them and put them on these ventilator settings, the patient's blood pressure falls precipitously and he becomes bradycardic. The ventilator alarms, it has high pressures, and on exam, there's diminished air movement throughout. The breath sounds are equal bilaterally. What is your most appropriate next step? Should you remove the endotracheal tube and attempt re-intubation? Do you think it's in the wrong place? Should you pull back the endotracheal tube 3 centimeters? Should you temporarily disconnect the ventilator from the endotracheal tube? Should you, this time, place bilateral chest tubes or tube thoracostomy? Or should you administer subcutaneous epinephrine? Oh, that was me. I'll do the answer. Yeah. So this is one of my favorite situations, and this can happen with COPD, it can happen with asthma, it can really happen with anybody. Um, but if somebody is decompensating immediately after intubation, you want to think about your differential diagnosis is their primary process the reason they got intubated? Is this getting worse and I need to do something about it? Is it a procedural effect? Have you ended up putting the ET tube in the wrong place? Is it in the esophagus? So you're not actually ventilating them. Is it a main stem intubation where it's gone in one side, more likely the right side than the left side, just due to anatomy? Or are they having problems from the induction meds that you gave them, often hypotension? Or is it a problem with positive pressure? So have they developed a tension pneumothorax because you put so much pressure and then you pumped a lung? Or are they having dynamic hyperinflation or auto PEEP, which is what's happening to this patient? So when you have a patient, especially people that have obstructed airways, asthma or COPD, they have very, very narrowed airways. And so they're not as able to get air out because you have to squeeze the air out against really, really narrowed airways. And so air tends to get trapped and in the periphery, and you can't squeeze it out of those really narrow airway passageways. And so when they end up trapping air, they have increased intrathoracic pressure. When that happens, they get decreased venous return, they get decreased cardiac output, and sometimes they can arrest. So the answer is really simple. You just disconnect the ventilator. It feels very scary, but you want to disconnect the ventilator. And often you actually want to push down on the patient's chest. So you're manually removing the air that they have trapped, pushing it out of their airways, and then you can reconnect them, often with a lower tidal volume or respiratory rate to allow them time to get the air out. So you do just that. The patient stabilizes and you return him to mechanical ventilation with a lower tidal volume. The new ventilator settings are volume control. Tidal volume has gone from 800 to 500 with that rate of 20 breaths per minute. A repeat ABG reveals 755, PCO2 of 42 with a PaO2 of 120 and a bicarb of 38. What is the most appropriate next step? Should you increase the tidal volume to 750, just shy of the 800 that got you into this trouble? Should you administer acetazolamide? Should you decrease the respiratory rate to 12? Should you change to pressure control ventilation, or should you continue your current management? We'll give just a couple seconds because we're running on time. Okay. We got most for C, some for E. Okay, so the answer is C, decrease the respiratory rate to 12. So for this patient who looks like they probably have a baseline elevated serum bicarbonate in compensation for chronic respiratory acidosis due to their COPD, it's important to remember that your goal is not to normalize your goal is to normalize the pH. Your goal is not to normalize the PCO2. So if we go back to this patient, their PCO2 is normal by the books, but their pH is high because they are used to a higher PCO2. So you actually want to decrease their respiratory rate. So they're clearing less CO2, they rise back to their normal, and you normalize the pH, not the PCO2. And this becomes relevant. You all have probably had this happen when you're trying to extubate someone. And if you have normalized the PCO2 in a patient who does not have a normal baseline PCO2, and you have made their pH alkalotic, when you put them on a spontaneous breathing trial and you say breathe, their brain says, nope, I want to retain carbon dioxide to lower my pH in a normal range. And so they actually are apneic on their SBTs. So for patients who have normal acid base abnormalities, you want to mind those as you're managing their mechanical ventilation. For the sake of time, I'm actually going to skip through this next question, but I will. Sharing the main punchline of this question: worth reviewing sedation and analgesia pearls because the boards may ask you. Spontaneous awakening trials and spontaneous breathing trials are core management in ICU medicine and are something that's evidence-based. So the things that we know are under sedation and analgesia is that daily interruption of infusions improves outcomes. We should do daily sedation vacations or spontaneous awakening trials is the other name for that. And these should be coupled with spontaneous breathing trials because those can improve outcomes and get our patients extubated quickly, reduce delirium. Early mobility can improve our patient outcomes in the ICU. If they ask you questions about how to design a sedation regimen for a patient in the ICU, you want to use boluses where you can, so PRN meds where you can, if you can avoid a continuous infusion of the same drug. Opiate-only regimens, because we know we want to treat pain first. Really avoiding benzodiazepines, if possible, can improve outcomes. And so usually how we'll build a standard sedation regimen is that we'll do some PRN opiates. I often use hydromorphone, some people use fentanyl, it's just practice difference. Propofol is something that we can use because it's a quick on and quick off, and use that as an infusion if we need some sedation on top of our pain control. Dexmedetomidine, also really common to use, and there's situations where you use propofol over dexmedetomidine. Probably they wouldn't ask you those on the boards for internal medicine, though fair game for critical care. And benzodiazepines are last. Next principle to go through is how to manage blood sugar in the ICU. And so the evidence from a number of years ago that still stands as the foundation of our practice in glucose management is that we want to maintain our blood glucoses in the 140 to 180 range. Using tighter control actually decreases mortality. And we know that there's complications, particularly in surgical populations, if we go above about 180. So you want to you want to direct your treatment of blood sugars to try to get a blood sugar in the range of 140 to 180. There's different ways to do that, and depending on your patient, there's different choices. But I think that 140 to 180 of being your goal is something that they could ask you. Probably wouldn't ask more details about how to do that. Next principle is going through transfusions in critically ill. This has been the practice for most of your careers if you finished residency recently. We know that unless a patient is actively bleeding or unless they have acute coronary syndrome, and maybe some other niche categories. We should transfuse to a hemoglobin of 7 and not greater than 7. Data looked at 7 versus 10 and better outcomes, less blood, fewer complications, aiming for 7 over 10. This doesn't apply in patients who are actively bleeding, but in hemodynamically stable non-bleeding patients, hemoglobin of 7 is our target. Here's the data review of the TRIC trial that showed us that. Saves a lot of money, fewer complications. The last category in boards to pay attention to under critical care is toxicology. We'll go through this question and then I'll flip through some slides for review later. A 27-year-old man is unresponsive on arrival to the ED. He has a severe anion gap, metabolic acidosis, and urine microscopy is shown here. So you start IV fluids. His mental status is so poor that you intubate him for airway protection. And what's the most appropriate next step in management? Should you begin a bicarbonate infusion? Should you administer physostigmine? Should you administer atropine? Should you administer fomepizole? Or should you continue supportive care? Okay, great. We have a lot of votes, about 3/4 of people for D, administered fomepizole, and then a couple for the other categories. So the answer is fomepizole. And so this is a reminder to review your toxic alcohols and when you might suspect one over the other, looking at your anion gap and looking at your osmol gap. So ethylene glycol, you can have crystals in urine, and so that's what they were going for. And so fomepizole is your antidote of choice. You also can use dialysis to clear the ethylene glycol in those situations. Fomepizole can sometimes avoid some of the renal failure, though, so is a priority. You should suspect toxic alcohols when your osmol gap is greater than 10, and I think that's reasonably fair game for something they might ask. I won't read through this, but do review it on your own time to recognize toxidromes that go with different ingestions, the clinical syndromes that you might see, and then what you might do about it. No specific antidotes, because those are great items to list in an ABCD option to ask questions about. And then this last question is getting at serotonin syndrome and neuroleptic malignant syndrome. Worth reviewing the different presentations of those because they have different patterns, though can often clinically look similar with some differences. The treatment for both is to stop the offending drug, to give benzodiazepines, and if you have to, use neuromuscular blockade, though often we avoid that. Specific antidotes to each one: serotonin syndrome, cyproheptadine, versus neuroleptic malignant syndrome, bromocriptine or dantrolene. Okay. Thank you all for your time and going through a lot of information really quickly. Please feel free to reach out to me if you have questions. I'm sending in the PDF version of these slides, so if there's some stuff that doesn't come up quite right, let me know. We use Google Slides, and it doesn't allow me to share those outside of PDFs. So if something doesn't come through, please let me know. Thank you guys so much. Good luck. You're going to do great. And good luck in your future practice. This is an exciting time.
Thank you so much, Dr. Ragland. That was fantastic.
Yeah.
As an outpatient doc, I really appreciate getting the updates on critical care.
Thanks again for the invitation. Have a good rest of the course.
Thank you.